Hello, hello, coders. Good evening. Welcome to study group session 4. As usual, the purpose of this group study it's to review scenarios so that prepare you for your CPC exam. Hope you guys are ready. Mr. Sandeep has a lot of cases that you guys are going to enjoy. So now, without further ado, we're gonna introduce our team. We have Mr. Sandeep. You wanna come and say hi, Mr. Sandeep?
Hello everyone, hello coders. It's a week 4. Welcome you all to the week 4 of study sessions by AMCI. As Miss Eva said, we have got some interesting, some good scenarios waiting for you all, and let's rock and roll. Thank you, Miss
Thank you,
Eva.
Mr. Thank you, Mr. Sandeep. Now, that's me. Hello, coders. I hope you're having a great night. Now, our wonderful Miss J.
Hello, 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 everyone. All right, I think we have a lot to do, so I'm going to hand it over back to you, Miss Eva, and I'll see you coders in the chat.
Thank you, Miss J. Now we have Miss Anu. Miss Anu, would you like to say hi to the coders?
Yeah, hi, Miss J, and all the organizers and coders. Warm welcome you all, and we catch up with the chat.
Uh, thank you, Miss Anu. Miss Courtney.
Hello, coders. Good evening. Welcome to another group study. We've got some awesome things for you guys tonight, and I think you're going to like it. So I will talk to you in the chat.
Thank you, Miss Courtney. Now we have Miss Carla.
Good evening, everyone. Good evening, coders. Let's get it. Let's code.
Awesome. Thank you so much, Miss Carla. Now we have Miss Vivian.
Hey coders, welcome to this week's group study. I hope you had a good break and you're ready to code with your awesome instructors.
Thank you, Miss Vivian. And we have Miss Dolly, but she has a little bit of tech issues, but she will be in the chat with all of you guys. Now, for this week, the goals of the presentation, we have radiology scenarios, pathology scenarios, and medicine scenarios. Now, how to solve a multiple choice case study scenario for the board exam. Surgery. Highlight your key terms. Remember, the yellow is for the diagnosis, green is for procedures, and pink is for the inclusive. Document your inventory procedures and diagnosis. Select primary. Review guidelines. Select the code that best matches your inventory list. Now, when highlighting, do not highlight the following. Things observed by the physician. Closures, sutures, staples, etc. Hemostasis, bleed control. Drains, irrigation of the surgical site, installation and removal of clamps and trocars, dressings, surgical risk. And now, how to solve multiple choice cases scenarios for the board exam for non-surgery. So you're going to highlight your key terms, which is the yellow for diagnosis, green procedures, pink inclusive. Your key terms are procedures, diagnosis, and the FTRs. So, FTRs are your facts to remember. And review your guidelines. Select the code that best matches your inventory list. And chun your books. Now I'm gonna transfer to Miss J, which she's gonna talk to you about how to chun your thyroid CPT section. Miss J?
Yes, yes, yes. Thank you so much, Miss Eva. All right, I am going to change presenters to me. Just a moment, and it does take me a little while. Bear with me. Here we go. Chun. All right, so what I'd like to do is give you a little chun of the endocrine section, if you will. And this section is a section coding for thyroidectomies. And sometimes we have a little difficulty deciphering the codes and their meanings. So if you want to follow along, go right ahead. But code 60210, partial thyroidectomy unilateral with or without isthmusectomy. This is coding for any part of one lobe. In the same family, 60212, this is with contralateral subtotal lobectomy, and this includes the isthmusectomy. Any part of both lobes, horizontal cut. So both lobes, any part of both of those lobes cut horizontally. 60220, this is total thyroid lobectomy, unilateral, with or without isthmusectomy, and this is one entire lobe. Now we get down to 60225. This is, of course, we've read the parent in the common portion language. The indented is with contralateral subtotal lobectomy. In other words, this is one entire lobe and part of the opposite lobe. All right, so hopefully you understand that. And we're going to move on to 60240. This is your code for thyroidectomy, total or complete. In other words, this is a total thyroidectomy, both lobes. All right, if it's total or complete, that I believe is referring to the isthmusectomy as well. Now, when you get down to family 60252, this family is coding for malignancy. That means the patient is having the surgery for cancer. 60260 is coding for the remaining tissue. Sometimes they don't get it all during an initial procedure, and they go back in and take out the remaining surrounding tissue. All right, 60270. This is thyroidectomy, including substernal thyroid. And this is the entire thyroid with substernal or sternal or transthoracic approach. All right, they're going through the chest. And that's pretty much it. This is how you should document for these thyroidectomies. But some of you might say, well, I still don't get it because I'm more visual. All right, I have something for you. All right. So 60210, this is a partial thyroidectomy unilateral. Like I've said before, this is any part of one lobe. 60212, with contralateral lobectomy, subtotal lobectomy. And this is any part of both lobes cut horizontally. And it does include the isthmusectomy. See, it's including it. There's no option. 60220, this is total thyroidectomy unilateral. It's one lobe, one entire lobe, or one lobe with the isthmus. 60225, with contralateral subtotal lobectomy. With contralateral subtotal lobectomy, it's up to 3/4 of the thyroid. And 60240, thyroidectomy, the complete or total thyroidectomy. There you go. So hopefully that helps. All right, so I'm finished. I'm going to hand it over to Mr. Sandeep and Miss Courtney. Take it away. And let me know in the chat if this helps you.
Thank you, Mrs. J, for that amazing example on the chart. So, coders, let's move on to the first scenario of the day, and I would like to invite Miss Courtney. Miss Courtney, would you please read this scenario for me?
Absolutely. All right, coders, so I'll read the questions first. What CPT and ICD-10 CM codes are reported for the anesthesiologist? What is the time reported for this service? Is it A, 00640 modifier AA, P3 M48.061, B, 00630 modifier AA, P3 M48.061, C, 00620 modifier AA, P3 M48.061, or D, 00670 AA, P3 M48.061. Anesthesia start time, 1407. Anesthesia end, 1733. Physical status, 3. Anesthesiologist, Michael D., MD. Operative report. Preoperative diagnosis, lumbar spinal stenosis. Postoperative diagnosis, L4 to L5 spinal stenosis. Procedure, L4 to L5 laminectomy, removal of synovial cyst, bilateral medial facetectomy, and posterolateral fusion L4 to L5 with vertebral autograft, bone morphogenic protein, chip allograft, all with intraoperative somatosensory evoked potentials, electromyographies, and loop magnification. Anesthesia, general endotracheal anesthesia. Description of procedure. The patient was taken to the operating room and underwent intravenous anesthetic and orotracheal intubation. Her head was placed in the 3-pin Mayfield headrest. She was turned into the prone position on a 4-poster frame. All pressure points were carefully padded. The fluoroscope was brought in and sterilely draped to help localize the incision. A midline incision was made between L4 and L5 through skin and subcutaneous tissue, and the paraspinal muscles were dissected free of the spinous process, lamina, facets, and L4, L5 transverse processes. Self-retainers were placed more deeply. We proceeded to use the double action rongeur to remove the L4 to L5 spinous process lamina. 3 and 4 millimeter Kerrison punches were used to complete the laminectomy, including removing the hypertrophied ligamentum flavum. We made sure that we decompressed from the top of the L4 pedicle to the bottom of the L5 pedicle, which was confirmed with intraoperative fluoroscopy. The medial facets were drilled, and then we undercut over the nerve roots with a 3 millimeter Kerrison punch. Hemostasis was achieved with powdered gel foam. We irrigated the wound. We decorticated the L4 and L5 transverse processes. We placed our vertebral autograft, bone morphogenic protein, and chip allograft in the posterolateral gutters. Hemovac drain was placed. We closed the muscle with 0 Vicryl. Fascia was closed with a 0 Vicryl. Subcutaneous tissue was closed with 2 0 Vicryl, and the skin was closed with staples. All right, coders, you have 2 minutes to solve the problem.
That's almost 1.5 minute coders. I'm sorry, I'm stopping you here. Please, if you haven't still completed, please move along and put your answers in the chat while we are discussing this scenario. We got a little bit a long way to go today in the session. That's why I'm stopping here. So let's move along and let's see the correct answer for this scenario. As I can see in the chats, many have already answered it. The correct answer will be answer B, option B. So the first step comes highlighting the keywords. You can see the anesthesia start time and the end time here. It's 1407 and end time is 1733. We have a physical status modifier 3 and anesthesiologist is Michael D. MG. And the post-operative diagnosis is L4, L5 spinal stenosis. The procedure performed L4, L5 laminectomy. A removal of synovial cyst was performed. A bilateral medial fasciectomy was also performed, along with posterior lateral fusion of L4, L5, a vertebral autograft, a bone morphogenic protein chip allograft, and intraoperative somatosensory evoked potential ultramyographies and loop magnification was also done. The anesthesia given in this procedure is a general endotracheal anesthesia, and intravenous anesthetic and orotracheal intubation was given to the patient. The patient was placed in a prone position. A fluoroscope help was used. Then a midline incision was made through the L4, L5 through the skin, subcutaneous tissue, paraspinal muscles were dissected to remove the L4, L5 spinous process. And a 3 and 4 millimeter Kerrison punches were used for laminectomy and removing the hypertrophied ligamentum flavum. What we got then, we have then decompressed. Intraoperative fluoroscopy was used. Medial facets were drilled. Undercut over the nerve roots was made using the Kerrison punches, and we decorticated the L4, L5 transverse process, and vertebral autograft, bone morphogenic, and chip allograft was then placed. So as I said, the correct answer to this question will be answer B. And we have got some guidelines here, FTR here. We have to see whether it's a surgical procedure. We have to check the diagnosis, the time, the provider type, physical status, qualifying circumstances, and only used for general anesthesia or blocks. So before moving along, let me show how churning helps to solve this scenario much easier, how it helps us to save the time during the exam. So you can see the code series from 00600 to 00604. It is coding for anesthesia on the cervical spine. And the code series 00625 to 00626 is coding for anesthesia on the thoracic spine and code. And we have 00630 to 00635, which is coding for anesthesia on the lumbar region as well. Coming to the first option, option A, how did I cancel off that option? It is coding for anesthesia for manipulation of the spine for the closed procedure. Well, was we having a closed procedure here? If you remember, we had a midline incision. Okay, we had a midline incision made between the L4 and L5, and it was not a closed procedure, it was an open surgery. That's how we canceled option, the first answer, option A. Here we go. And let's look into the next one, 00620. It is coding for anesthesia for procedures on thoracic spine. Well, coders, as I said, other churning helps here. Was a procedure performed on the thoracic spine? What do you think? Was it performed on a thoracic area? No, it was not. It was performed on a lumbar area. Yes, it was not performed on the thoracic spine. It was performed on the lumbar area. You can see here, it was performed on L4, L5. It was done for the lumbar stenosis. So that cancel out option C as well. Here we go. And the next one is option D. that is coding for 00670. Anesthesia for extensive spine and spinal cord procedures. It involves a spinal instrumentation or vascular procedure. Our was not an extensive spinal cord procedure. There was no spinal cord, spinal instrumentation or vascular procedures involved. Now let me show what has been done in the scenario which we are having. In our scenario, a synovial cyst was removed, a laminectomy was performed, a medial fascectomy was performed, and then what they use is a vertebral autograft amorphogenic protein was used. So you can see in this image, this is for a laminectomy. You can see a laminectomy performed here. So laminas are these portions which form the roof of the spine. So L4, L5 laminectomy was performed. The patient is having a spinal stenosis where there will be a growth of a bone. It will decompress the nerves in between. So by removing the lamina L4, L5, the decompression will be relieved. Along with it, we had a fascectomy also performed. A portion here was removed. Once again, it helps in relieving the compression on the spinal nerves. And this is the fascectomy image. This was also removed, and all the transverse process also will be removed. If you remember the diagrammatic representation of those facets and lamina, you will have able to understand this much easier. And as I said, a synovial cyst was also removed. So this is all about what procedure performed. And then they took a graft. What they took a vertebral graft, a bone morphogenic protein, and then they place it over here in order to enhance the spinal fusion of the bones. So that's all about the procedure performed in our scenario. And as I said, the correct answer will be option B, 00630. So coders, if you're having any doubt on this scenario, please put it in the chat. We'll be happy to help you. And meanwhile, let's move on to the next scenario. I'm sorry, I forgot one more thing. There was one more question in this. What time reported for the service? What is the anesthesia time reported for the service? Coders, put your answers in the chat. What is anesthesia time for this procedure performed? Please put your answers in the chat. Yes, that's correct. Let's move on and check the answer. How did you got that answer? We will minus the anesthesia end time from the anesthesia start time. That will give you a time around 206 minutes. That's the time which is given, anesthesia time given, and when we convert them into the units, we will divide them by 15s. That will give us an answer of 13.7. So rounding it up to 14 units, this is your anesthesia units, and your anesthesia time is 206 minutes. How do you feel about that? Are you following? Okay. Okay, coders. Thank you. So, okay, coders, let's move to the next scenario. That's all we are having on the anesthesia. Now it's time to move on to the radiology section. And who do we have? I would like to invite Miss Carla. Miss Carla, can you please come up on and read this scenario for me?
Yes, and we're going to read the answers first. What are the CPT and ICD-10 CM codes reported? A 77047 modifier 26, Z 12.31, Z80.3. Answer B, 77066, Z12.31, Z80.3. C, 77067, Z12.31, Z80.3. D, 77067, modifier 26, Z12.31, Z80.3. Case 1. Location, Imaging Center, radiologist employed. Study, mammogram bilateral screening, all views producing direct digital image. Reason, screening, bilateral digital mammography with computer-aided detection, CAD. No previous mammograms are available for comparison. Clinical history. The patient has positive family history of breast cancer. Mammogram was read with the assistance of GEICAD, computerized diagnostic system. Findings, residual fibroglandular breast parenchymal tissue is identified bilaterally. No dominant speculated mass or suspicious area of clustered pleomorphic myocalifications are apparent. Skin and nipples are seen to be normal. The axilla is unremarkable. Impressions. BIRADS, BIRADS 1 dash negative. All right, coders, you have 2 minutes. Let's get it. Let's code.
I don't think coders you need like enter 2 minutes to solve this scenario, and I can see most of you have placed your answers in the chat, and there's a split between B and C. I think it's C and D. Yes, it is C and D. Thank you, Miss Carla. I forgot to thank Miss Courtney on the last scenario as well. Thank you. I couldn't have done this without you. Thank you for reading those scenarios for me. That modifier almost had, yes, the modifier is a tricky thing in this scenario. Let's move along and solve this one. So highlighting the keywords, imaging center, radiologist employed, and let me say the first line, the radiologist employed is going to play a key role in arriving at the correct answer for this scenario. The study is mammogram bilateral screening. The reason for the visit was screening, and bilateral digital mammography was performed with a computer-aided detection. The patient had a family history of the breast cancer. That might be the reason why the patient came for the screening. And findings, we have residual fibroglandular breast parenchymal tissues bilaterally, and final impression is BIRADS negative. So the next step comes having our procedure inventory as well as diagnosis inventory. In the procedure inventory, we're having a screening bilateral digital mammography with computer aided detection performed, and it was done in an imaging center, and the radiologist was employed. Well, in the diagnosis inventory, we are having a screening. The patient arrived for a screening, and family history, she was having a family history of breast cancer. And these are our code options. Once again, throughout this session, you will see more scenarios where it was more easy to arrive to the answers if you are having your books chunked. So this is another example where I had my CPT book chunt, and this is the way I done those chunning. You can see the code 77046777047, which is coding for MRI of a breast, and the code series from 77065 and 77066, which is coding for diagnostic mammography, and the code series code 77067 is coding for screening mammography. Well, directly looking into this chun and looking into the procedure inventory, I can see, like, I can arrive into my correct answer. So I would select the CPT 77067 because that is matching, best matching my inventory. And let's do the due process. Let's start the process of elimination. Looking into the option A77047, as I said, it is coding for an MRI of a breast. We didn't had MRI here. What performed was a mammography, which was a screening mammography. So it was not an MRI. Here goes option A. Let's look into option B, 77066, which is coding for diagnostic mammography. Well, what's the difference between a diagnostic and screening mammography? The diagnostic mammography are done for a patient who is like having a suspected neoplasm or a lump or a breast, and he or she is coming for a diagnostic purpose. Those are when we go for these code series, the diagnostic mammography code series. In the other end, we are having a screening where the patient will be having no such condition. He or she will be just coming to have their screening done. Those are when we code the code series of 77067, the screening. And as I said, in our scenario, it was not a diagnostic screening performed, and that there goes the option B as well. Now let's come to the last two options, and this is where we had a split, the 77067. Which is coding for screening mammography bilateral, and the split was due to this particular modifier, the modifier 26. So what is modifier 26, coders? What is modifier 26? Professional component. Yes, modifier 26 is coding for a professional services alone. And I hope you remember this particular this particular information which we had from the last class, I think in the previous CPT class, part 3 class. So when the facility and the provider is employed by one entity, when the facility and the providers are employed by single entity, we won't be using any professional component or any technical component. We'll be going for a global service. There will be no modifier. And there's the point which I said in the first line. This is going to determine the answer, like how we get the correct answer for this scenario. You have seen here the radiologist like employed by the imaging center. So the facility and providers were employed by single entity, and in this scenario we won't be using any professional component, neither we will be using the technical component. And that is how, see, when the facility and the providers are employed by one entity, go for a global service. And that is how we eliminated option D. And our correct answer would be option C, 77067, Z12.31, Z80.3. How do you feel about this scenario, coders? Was this an aha moment? Was this a teachable moment? Please put in the chats. In the meantime, I will go to the next scenario, case 4 scenario. And I would like to invite Miss Vivian. Miss Vivian, can you please read this scenario for me?
Of course. So what are the
Miss Vivian, we can't hear you.
Yes, Miss Vivian, are you there or have you muted yourself?
That's okay, Miss Vivian. I'll read it for you. I'll go ahead, Mr. Sandeep.
Thank you, Miss Eva.
Case 4, location, independent diagnostics testing facility, radiologists employed by the facility. CT brain, head with without contrast exam. CT head without and with contrast August.
G23.8? What?
And
Yeah, go
yes, we
ahead.
are
I'll
having
keep on reading.
Miss
Okay.
Vivian here.
You're breaking up.
Yeah.
With contrast. Oh,
Location. Oh, sorry.
go ahead.
Independent
We,
diagnostic testing
yes, we
with
will
contrast.
redo this. We will redo this. We'll start from the beginning. Miss Vivian, you can go ahead.
Okay. Location, independent diagnostic testing facility, radiologists employed by the facility, CT brain head with and without contrast exam, CT head without and with contrast August 5th, 20XX, comparison, none available, history, non-small cell lung cancer, technique, axial images of the calvarium without and with 125 cc Omnipac 300 intravenous contrast. Findings. The calvarium is intact. Imaged upper portions of the maxillary antra show minimal mucosal thickening. The sphenoid, ethmoid, and frontal sinuses are clear bilaterally. No hydrocephalus, mass effect, brain shift, abnormal, extraaxial fluid collection, or mass. Calcification left basal ganglia without mass effect, nonspecific, likely benign. Abnormal but nonspecific decreased density in the paraventricular and subcortical white matter of the cerebral hemispheres bilaterally without mass effect or enhancement, most consistent with remote microvascular ischemic change present to mild degree. Bilateral intracavernous carotid and vertebral arteriosclerotic calcification. Probable anterior communicating artery aneurysm 6 by 5 millimeters. Recommend intracranial CT angiography to further characterize. Conclusion 1. No findings suggestive of metastatic disease. 2. Probable 6 by 5 millimeter anterior communicating artery aneurysm. Recommend intracranial CT angiography to further characterize. 3. Cerebrovascular arteriosclerosis. 4. Nonspecific cerebral white matter lesions most consistent with remote microvascular ischemic change. 5. Calcification left basal ganglia, likely benign. However, recommend continued imaging follow-up. Okay, coders, your time begins now.
And that is time. And I think you got the trick this time around. If anyone please need the extra time, please go ahead and solve the scenario. Since we are running out of time, we have little time only today and a lot of scenarios to cover. I'm little going at a little pace today. And now let's move on. And thank you, Miss Vivian, for that. Thank you, Miss Vivian, reading those scenarios for me. And let's move on and highlight the keywords. Independent diagnostic facility, testing facility. Once again, you can see here the tricky word, radiologist employed. And what was a procedure performed? It was CT of a brain or head with contrast followed by without contrast. And he or she is having a history of non-small cell lung cancer. The techniques performed without contrast followed by contrast. This is another tricky word in this scenario. And conclusion, no findings suggestive of metastatic disease. We have a probable 6 × 5 millimeter anterior communicating artery aneurysm. Since this is a probable conditions, probable condition, we don't code it here. So probable condition we won't be coding. And next we are having a cerebrovascular arteriosclerosis, a non-specific cerebral white matter lesion, calcification left basal ganglia. And here are the procedure and the diagnosis inventory. In the procedure inventory, we are having CT of a brain or head, which is performed without contrast, followed by with contrast. And diagnosis, small cell lung cancer. I've placed a probable 6 × 5 millimeter anterior communicating artery, but aneurysm. But as I said, we won't be coding this. And we are having non-specific cerebral white matter lesion. We are having calcification, left basal ganglia, and cerebrovascular arteriosclerosis. So these are our ICD and these are our CPT options which we have. And this is how I done my turning. I have two sets of code series here. The code series from 70450 to 70470, which is coding for CT of head. And I'm having the code series from 70544 to 70546, which is coding for MRI of the head. And let's look into option B, 70546. This is coding for MRI of the head. Let's cross check with the procedure inventory which we are having. We haven't performed an MRI in our scenario. We performed a CT scan of the brain, and that was without contrast followed by contrast. So option B is the wrong one. Let's look into next one, 70460, which is coding for CT of the head or brain with contrast materials. Once again, the tricky part, there is an exam without contrast followed by a contrast. So it was not just a contrast which is given. First we had without contrast followed by contrast. That cancels option C as well. The remaining two options, which is having the same CPT, 70470, which is coding for, let me see what it is coding for, CT of head or brain without contrast materials followed by contrast material and further sections. Now this is matching my procedure inventory, CT of brain without contrast followed by contrast materials. But what differentiate between option A and D is a modifier. Once again, option A is having a technical component, TC. And once again, here the radiologist was employed by the facility. And as I said in the previous scenario, when the facility and the providers are employed by one entity, we won't be using any professional or technical component. It will be a global service. As in last scenario, this is also a global service, and we won't be using a technical component. That leads to the correct answer, option D, 70470. Most of you have got this one correct. ASTC is going for a technical component, so most of you have said this one correct this time around. And I hope that's okay. Okay, and I hope this cleared your doubts regarding the global service. Do you have any doubts, coders? Please put in the chats and we'll be on it.